Welcome to the deep dive. Today we are pulling back the curtain on the quiet but really critical foundation of what we now here call the Internet of Bodies, or IoB.
That's right. And this isn't some flashy new trend that just appeared. It's a fully regulated reality that's been built on more than 2 decades of some pretty intense planning.
And we're going to get into those plans, we're diving into the sources, and we're really focusing on this crucial moment in time, a March 2015 joint workshop. It was convened by the FCC and the FDA.
And that meeting was so pivotal, it's where they laid out the technical and regulatory groundwork for what we're now calling digital healthcare 4.0.
Okay, so let's unpack that, because what immediately jumps out from the source material is the timeline. This whole convergence, which the documents call Connect to Health, or C2H, it is not new at all.
Not at all. We're talking about regulated wireless systems for medical use that go all the way back to the med radio systems in 1999.
1999. That's 2 decades of planning before the IoB even became a buzzword for the public.
Yeah. And that early planning was so critical because the core mission, it's always been the same.
Which is?
Making sure that life-critical medical devices can safely coexist in what's become an incredibly crowded wireless environment. I mean, think about it. Wi-Fi, Bluetooth, cellular signals, it's technical chaos out there.
So the agencies needed a plan to manage all these complex issues of coexistence, interoperability, and, of course, security for the tech we rely on every single day.
Exactly.
So let's start by defining the perimeter of this IoB, because the sources are incredibly specific about the hardware that was being planned for. They break it down into 3 main categories of medical sensing devices. First up, and maybe the most novel, are the ingestibles.
Right. These are your smart pills. They use wireless tech, often these tiny microradios, to monitor what's happening inside your body.
So like tracking if you took your medication.
That, or even identifying issues in your digestive tract and then transmitting that data out to a receiver, something you'd wear or that your doctor would have.
Then you have the most common category, the one people probably know best, the wearables.
For sure. These are the wristwatches, the patches, sensors that are literally woven into your clothes.
And they're just constantly monitoring vital signs, heart rate, blood pressure, body temp.
It's continuous passive monitoring. The idea is to replace those sporadic doctor visits with a constant stream of data.
And finally, the category that seems to need the most regulatory foresight, the embeddables.
Yeah, these are miniature, really sophisticated devices that are inserted under the skin. And we're not just talking about pacemakers anymore.
What else are we talking about?
Well, bioelectronic tattoos, advanced neurostimulators, things that need constant, totally reliable wireless access, but are, completely dependent on the body's integrity.
And if we connect this back to the regulatory infrastructure, this isn't just about the tech, it's governmental. The airwaves are the FCC's turf, device safety is the FDA, and then critically, payment and adoption is CMS Medicare.
And the sources highlight the huge leverage that was used to drive this adoption across the country.
Huge is the right word.
It is. The sources point to the scale of this push, specifically mentioning the $50 billion Rural Health Transformation Program.
$50 billion? That's not pocket change.
No, it was a massive financial carrot, a way to incentivize states to adopt all the required biodigital communication protocols. When you attach that kind of money to a tech shift, voluntary adoption pretty quickly becomes a financial mandate.
Which would drastically speed up the whole rollout of this infrastructure.
Exactly. Puts the timeline in perspective.
It does. And the key technical term that makes all this remote monitoring work, whether it's from a device inside you or from a remote clinic, is biotelemetry.
Biotelemetry is just the remote measurement and transmission of biological data. So heart rate, glucose levels, oxygen saturation, but sent from a distance.
And the ITU, the International Telecommunication Union, they played a huge role in standardizing this, right?
A massive role. They standardized these systems globally and specifically reserved frequency bands like the 402 to 405 megahertz MICS band.
MICS being the medical implant communication system.
That's the one. They basically carve out these tiny protected frequency lanes to make sure that a critical medical transmission doesn't just get drowned out by everything else.
That need for dedicated safe lanes.
Yeah.
It brings us right to the core problem from that 2015 workshop, the technical challenge of coexistence. The problem is that your everyday gadgets, your headphones, your office Wi-Fi, They have to safely coexist with these critical, often life-sustaining medical devices.
And this is where the complexity just explodes, because even when you have standards like 802.811 for Wi-Fi, device vendors, especially in the medical field, they integrate proprietary chipsets. They make their own custom software modifications.
So they might tweak the timing or the power levels or something in the channel hopping sequence just for their specific device.
Exactly. And the consequence of that is huge, isn't it?
It has to be. A medical device company, their specialty is anatomy or pharmacology, not necessarily advanced wireless engineering.
Precisely. They integrate a wireless interface, they modify it for their device's needs, and then suddenly that device might be hogging bandwidth or transmitting too loudly or at weird intervals.
And predicting how that will behave in a crowded hospital just becomes incredibly difficult.
Almost impossible without a new framework.
So to simplify this, to predict the complexity, experts from groups like WECAD, that's the Wireless and Electronics Compliance Assessment Division, they proposed a structured way to test performance.
That's right. Dr. Hosmer Fee, he stressed that the system's behavior had to be rigorously projected and tested across 4 critical domains.
Okay, what are those for?
Well, one is frequency, which is all about spectrum performance, making sure the signal stays where it should. 2 is space, which is about the environment, the geography. Does it work in a crowded elevator the same way it works in an OR?
That makes sense.
3 is environment, which means factoring in all the other competing tech nearby. And 4, which is really interesting, is time.
Time. Why is a time domain so critical?
Time is all about channel monopolization. If a medical sensor takes too long to send its data, or if its software makes it transmit at the exact same instant as 3 other devices, it can just crash a critical network function. So testing the time a device is on the air is essential for stability.
And we should probably highlight one specific frequency that came up over and over in the sources, the 2.4 gigahertz ISM band.
The industrial, scientific, and medical band, yeah.
It's often called the fast lane for wireless, but the sheer volume of devices using it means there's a really high probability of interference.
And that high-risk profile is what makes this robust, formalized testing mandatory. It leads directly into the big debate they had at the workshop about how this testing should even be managed.
Right, because experts were stressing that these test beds are essential tools, not just for a one-time certification, but for ongoing risk management.
They kept referencing these strict FDA guidance documents and ISO standards that require periodic risk assessment. This isn't a one-and-done thing.
Which leads to the core industry debate they were having. Should the testing rely on one central universal test bed, or should there be multiple specialized facilities?
The argument for the single, centralized model that was championed by organizations like Underwriters Laboratory, UL.
Their idea was to create a single program, maybe something like the Wi-Fi Alliance, that would prescribe use cases and define specific testing recipes.
The argument was all about efficiency, standardization, saving costs. Basically, get one ISO certification for all IoB devices, and you're good to go.
But the industry users, they pushed back on that hard. A representative from Medtronic pointed out that their devices operate on totally different frequency bands.
Yeah, 400 megahertz, 900 megahertz, 2.4 gigahertz. And they use these complex ad hoc networks that are outside the main hospital system.
So their point was basically, we need a separate crash test facility for a tiny pacemaker versus a giant mobile diagnostic machine.
It's a perfect analogy. And NIST, the National Institute of Standards and Technology, they chimed in and said the focus should be on repeatable methods, not just creating a static physical test bed.
So the goal wasn't just to prove a device works in one lab.
Right. It was to ensure the process of testing is standardized and repeatable no matter where you are.
And this all boils down to a really critical FDA requirement that was confirmed in the workshop. Manufacturers can't just test their own device test their DUT in a bubble.
No, they have to test the effect of their DUT on other devices and on the whole network in that environment. They have to make sure the performance of the entire system isn't degraded. It's reciprocal accountability.
But that raises a huge challenge, one the industry experts brought up. If the hospital's own network, the routers, the firmware, the access points, is constantly being updated, how can a manufacturer possibly guarantee their device's safety years after it was certified?
That is the million-dollar question, isn't it?
It really is. Does that mean the medical device maker is now responsible for the hospital's entire IT network? Did the sources say anything about who bears the liability there?
The sources confirm the immense technical burden is on the manufacturer. Their certification depends on the device performing under expected conditions. So, industry members stress the focus has to be on testing entire systems.
The device integrated into a real enterprise network.
Exactly. Singular device certification is just not enough when the environment is constantly evolving. They have to build a product that can adapt and prove it can adapt through rigorous testing.
This challenge of the leaky, crowded airwaves, which testing can only sort of patch up, it led to what I think is the most profound concept discussed in the sources.
I think I know where you're going with this.
The engineers decided if the current solutions all rely on testing these chaotic airwaves, what if we just bypass the airwaves completely?
And that is where the future gets a little mind-bending. The foundational work they were discussing led to a concept called human body communication, or HBC.
Human body communication. It sounds like science fiction. What does that actually mean technically?
HBC basically replaces the traditional physical layer of networking. For anyone who's not an engineer, the physical layer is just how data moves. Is it a fiber optic cable, a copper wire, or the airwaves?
Okay.
HBC uses the human body's natural conductive properties, it's called electroquasistatic capacitive coupling, to turn the body itself into a communication medium. It becomes the wire.
Wait, so if I have a sensor on my wrist and another on my torso, the data travels through my skin and my tissue instead of broadcasting a radio signal into the room.
That's exactly it. And for you, the listener, the significance here is massive. It allows for extremely low power and critically highly secure data transfer because the signal is confined almost entirely to the area right around the body.
It's a huge security improvement over traditional radio frequencies that just leak signals everywhere, creating chances for someone to intercept or hack it.
They're literally turning human tissue into a secure data pathway.
That is genuinely incredible. And it shows the depth of research that went into securing this system. And we know this foundational work from 2015 is now driving extremely rapid development in next-gen networks.
Oh, absolutely. The regulatory bodies are not waiting around. The FCC's Technological Advisory Committee is already actively preparing for 6G security and reliability risks.
Even though the full 6G standards aren't even expected until around 2029.
Right. And we know from the sources that 7G and even 10G testbeds and planning are already happening. The pace of this deployment is incredibly brisk, which just underscores why these agencies have to plan a decade or more in advance.
Okay, let's wrap up this deep dive. What we've seen today is that the digital future of healthcare, from ingestibles to remote monitoring, it wasn't some sudden technological leap that happened overnight.
No, it is built on a decade plus of intense regulated planning between the FCC, the FDA, the NIH, and NIST.
The central challenge has always been moving beyond just testing one device in a vacuum.
The goal now is to create reliable, repeatable methodologies that can secure these complex, constantly evolving systems, all while leveraging, the most intimate and secure wire of all, the human body itself.
So what does all this highly technical rapid development mean for you? Considering the incredible pace of 6G and 7G deployment that experts from the FCC and industry are already talking about, and the fact that this technology lives inside and on your body, the question we'll leave you with is this. How can the regulatory and manufacturing communities successfully bridge the inevitable gap between this incredible technological complexity and the awareness, comfort, and understanding of the average consumer?